Welcome to Legal Nurse Podcast. I'm Pat Iyer, the host of this show, and I am so excited to let you know that our next virtual conference is September 26th and 27th, 2024. I'll be sharing more information with you about this in the middle of this podcast and would recommend that you sign up now. The link for signing up for the conference is lnc.tips/September 2024 virtual. Now, let's get started. Welcome to Legal Nurse Podcast. I'm Pat Iyer, and today we're going to talk about an issue that commonly comes up in personal injury and medical malpractice cases, and that is hospital-acquired infections. I have with me an expert in epidemiology from a nursing perspective. She has experience running a large epidemiology department, infection preventionist department for a hospital that included 100 outpatient locations and a separate surgery center. I'd like you to meet Gwen Rogers. Welcome to the podcast, Gwen.
Thank you, Pat.
Let's start with the term nosocomial infection and just do a refresh on what that term means.
Nosocomial infection has actually been retermed to healthcare acquired infection. So it is an infection that is not present or incubating at the time the person receives their healthcare. So it becomes apparent after they start getting their healthcare or after they receive their healthcare and perhaps leave the hospital. It's estimated that 1 in 31 people who are hospitalized at any point in time have at least one healthcare associated infection.
Are those statistics specific to the US or are they international statistics?
That is specifically from the Centers for Disease Control. So that is probably related to the United States.
Okay. I know that we have an assumption that hospital-acquired infections are transmitted by the staff to the patient. Is that necessarily true all the time?
Bacteria can actually come from the patient themselves as we treat them. The bacteria usually gets into places that we don't want it, such as a sterile body cavity, because we put something artificial into the patient, such as a central line or a urinary catheter. And that acts as a pathway for that bacteria to get into those places. But another way we introduce the bacteria is by breaking technique. We don't wash our hands or we don't clean our equipment, and we bring that bacteria to the patient. Breaks in the skin from a surgical wound or an IV site, oppression injury can also give bacteria to the patient. But it isn't always bacteria. Patients can be infected with viruses or fungus while they're getting health care. During the height of the COVID pandemic, patients were getting infected with COVID from a roommate or a healthcare provider in the hospital. So it's not always the patient's own bacteria. They can pick up viruses or they can pick up other things while they're getting care in the hospital that is completely unrelated to the care that they are receiving.
And you know, from a legal perspective, attorneys are always interested in being able to pinpoint the cause of an infection. Can you give us a sense of how we can help the attorney answer that question?
We can do whole genome sequencing to identify potentially the cause of the infection. Sometimes it's a chicken or an egg. You can't tell if a healthcare worker who happens to have the same whole genome sequencing gave it to the patient or the patient gave it to the healthcare worker. It's used rarely and usually only when there's an outbreak in a facility. You can't really rely on that, but truly it doesn't matter. A HAI, which is a healthcare acquired infection's origin, doesn't matter. The fact that it wasn't incubating or present at the time of admission means that they acquired it in the facility. Origin is really irrelevant.
And I'm sure the origin doesn't change the medical treatment. If the attorney wants to say it was a break-in technique or a failure to wash hands or an unsterile procedure, that would be relevant from the liability perspective. And they're always interested in knowing, can I tie it back to a specific person or a specific incident? That's the part that is puzzling from a liability perspective. Do you have any thoughts about that?
Could ask if they have done whole genome sequencing. Most of the time it's not done, but causation is less relevant. You could say that just because it's a healthcare acquired infection, it is a potential side effect of any procedure, say surgery. They always tell you that infection is a potential adverse effect. But if you're having a procedure that is a elective procedure and it is a, say, class 1, which is a procedure that is not supposed to be infected, and your patient has an infection and perhaps dies from their infection, that is not an anticipated event from that infection. So where that bacteria came from is truly irrelevant. That is not a truly anticipated adverse event from that procedure.
In terms of a screening of a case, suppose an attorney comes to one of our viewers of this podcast, watching on our YouTube channel or listening on the audio channels, and says, I've got a case involving a patient who died from an overwhelming staph infection in the hospital. What are some of the screening questions? What are some of the screening aspects that the LNC should be looking at?
If I was looking at a case, I'd be looking at what interventions were done and what was the timing. For instance, did the patient have a peripheral IV that was put in by EMS? How long did that stay in place? We know EMS doesn't necessarily use sterile technique. They're life-saving. They just want to get that IV in to get fluids, to get medications in as quickly as possible. Most hospitals have a policy to get that IV out as soon as possible. Was it left in place? Were they using it in the hospital? If they used a central line, which is defined as a long line that ends in the great vessels around the heart, was that put in with sterile technique? Most places use a checklist to put that in. They use a co-pilot observation to make sure that sterile technique was observed during that insertion. Did that hospital use that checklist? Is that evident in the chart? How long was that central line left in place? What was the site looking like? They're supposed to observe that every day. They're supposed to make sure that that's necessary every day. Is that documentation in the chart? Are they using any caps or protectors on that central line to make sure that it is staying? How often are they changing the dressing? Is there documentation that they're changing the dressing? How many other IVs are in place? Are they leaving them in just in case they need them, or are they getting them out as soon as possible? What medications are going through that line? I'd be looking at all those things and the timelines of when they're in, when they're out. There's a lot to be learned from the medical record. What date was the culture done? What was the fever curve? Did somebody order cultures and then react to them? Was the culture result called to the physician as soon as the culture was done? Did they put them on antibiotics, and did they narrow the antibiotics to the result of the culture as quickly as possible? Those are all things that you can gain from the medical record that are very, very important to get on top of a patient who is becoming septic or has become infected.
That is quite a list, Gwen. I appreciate that. To go back to one of the first few things you said, did they use a pilot and a co-pilot? Can you break that down? That may be
Sure.
a phrase that's unfamiliar to others besides me.
Sure. There is the thought that having a person observe a central line insertion as a pure observer gives the person who is inserting the central line, or even a Foley catheter, a set a second set of eyes to make sure that there are no breaks in technique during the insertion. And if there was a break in technique, that second person is given the power to say, stop the line. And that is the same idea around the checklist that is done in the airline industry when they're starting up the engines to take off, that there's a person who is running the list and a second person who is being the second set of eyes to make sure that everything is done correctly so that the flight takes off successfully.
I had an opportunity to be an editor for a Romanian pilot who talked about how to apply the safety lessons of the airline industry to running a business. And he talked in his book about that checklist and how important it was to establish the team feeling, particularly when you're flying, because you may be flying every day with people you have absolutely never encountered before. There's a constant movement within the airline industry, just as there is with healthcare. A physician coming in to put in a central line may be working with nurses that they've never met before. So there has to be a standardization in place.
That is correct. Healthcare has adopted a lot of the airline industry standards in the operating room as well as at the bedside.
If we move on, Gwen, and think about the attorney is looking at this case, you've brought up some great points related to the diagnosis of the infection, the management of it, the monitoring of it. One of the questions that will come up is this indicative of the performance of this particular facility? In other words, are there any ways to determine, is there an infection rate in that facility? And is that discoverable? Can the attorney get their hands on that data? Before we continue, are you interested in standing out in a competitive market and attracting the clients you want to work with, and to do so in an effective way? That's going to be just one of the things that we'll concentrate in September at our September 26th and 27th, 2024 online conference. This is the 10th conference that Barbara Levin and I have collaborated on since July 2020, when we did our first online conference. We're going to focus on marketing, in particular, the marketing trends and the things that you can do specifically to attract more business. One of the questions that I see posted all the time on social media is, how do I get more work? How do I get my first case? We're going to focus on those answers to those questions at our September 2024 conference. That's September 26th and 27th. And you can get more information and grab your seat now at lnc.tips/September 2024 virtual. And now let's return to the show.
So facilities that participate in the Center for Medicare and Medicaid programs have a required elements that they are mandated to report to the National Healthcare Safety Network, which is a division of the CDC. There are a minimum data set that they have to report in order to participate in CMS. This is publicly reported, and an attorney can obtain that minimum data set. Many states require additional data set elements to be reported. These are reported out as SIRS, which is a standardized infection ratio. This, a SIR, is the predicted number of infections. Let's see, it's predicted number divided by the, let me double check this because I don't want to say this wrong. It is the observed number of infections divided by the predicted number of infections. So it is a ratio. We don't report out risks and rates any longer because rates aren't necessarily risk adjusted. So it wouldn't be fair to compare a small critical access hospital that has less than 25 beds to a 1,000-bed hospital and say that, the rates are the same when the population isn't the same. The CDC developed the SIR, the standardized infection ratio, which is risk adjusted so that you can compare SIRs. So you could ask a facility for their SIR for a specific infection. You may or may not be able to get it because it may not be an infection that they follow. Most facilities do a targeted surveillance, which would include their mandatories. They may do additional infections that are important to them on top of their mandatories. But there are some facilities that have to do a lot more. For instance, the state of Pennsylvania requires that all facilities do everything that is defined as an infection by the National Healthcare Safety Network. In Pennsylvania, you could ask for anything that has a definition and potentially get a SIR. So there is a caveat. If the predicted number of infections falls below 1, they cannot calculate a SIR. You might need to ask for a large amount of data, for instance, a whole year. So what is your infection for the year? Because you likely would have at least one infection in a year, but you can't get a quarter or a month. A large facility might be able to give you a quarter or a month, but a small facility, you might have to ask for a year worth of data.
So for example, something like Ebola or monkeypox, which is very rare, you would not expect to be able to collect data because you wouldn't, in a 25-bed hospital, expect to see a case of that in a year.
Correct. A centerline associated bloodstream infection in a small facility, you might not even get a SIR for a year. But a large facility, you may be able to get a month because they probably would have a SIR for a month.
And then you referred to the mandatories before. What does that mean?
All facilities who participate in CMS are required to collect centerline-associated bloodstream infections, urinary catheter-associated infections, colon infections, hysterectomy infections, MRSA bloodstream infections, and C. difficile diarrhea infections. So there are certain infections that every CMS facility is responsible for reporting. So everybody has to do that. Most facilities will collect something on top of that. For instance, the state of Maine has to report knee, hip associated infections, and other states are required to report other infections. It all depends on what state you're in.
Interesting that there isn't any standardization.
Other than that minimum data set, you can go above that. And then if you're not a CMS facility, if you're some other type of facility, there may not be a data set.
And let's be sure we define CMS facility for our listener.
So that's somebody who accepts payment from the Center for Medicare and Medicaid and is inspected by the Centers for Medicare and Medicaid.
And that is the healthcare system that covers our elderly for Medicare, and Medicaid is our poor citizens.
Yes.
Gotcha. Of course, hospitals always say, well, we treat sicker patients. That's why our infection rates are so high, because our population is very sick. How do you respond to that argument?
Well, that's why CDC went to the SIR, because the SIR is risk adjusted for the kind of population that is taken care of by a facility.
We've touched on some of this already when we talked about what you should be considering in screening a case of a hospital-acquired infection. Can you pull that together for us and help us think about the liability issues, first of all, related to diagnosis of infection and then to treatment? So let's start with the liability issues related to the diagnosis of an infection.
Sure. The liability is related to the fact that a healthcare associated infection accounts for extended length of stay, use of antibiotics, which is driving resistance in the United States and as well as other countries. It causes higher hospital bills. It causes loss of function. It can cause loss of jobs and unanticipated death. The crude mortality for someone who has an HAI versus someone who does not have a healthcare acquired infection is 2.5% higher. So there certainly is liability if someone acquires a healthcare acquired infection while they are under the care of a facility. And this is not just hospitals. Acute rehab facilities, long-term care facilities, any type of facility that provides healthcare can actually cause a healthcare acquired infection.
And does that tie back directly to behavior of the staff related to hand washing, for example, or am I being too simplistic?
Hand washing is the number one thing that a care person can do to stop the chain of infection. I think the second thing is to clean their equipment because they are what go between patient to patient to patient. Cleaning their hands between patients, cleaning their equipment between patients stops the spread of infection from one patient to another.
And you know, we put this within the context of the United States, and I have to tell you briefly about a trip that I made to India in 1972 when I met my husband's parents. His brother was a physician who took me to the local hospital, and it was a weekend. And there were big red splotches on the floor in the hallway leading up to the OR. He gave me a complete tour of this hospital. They were not operating at the time. And I said, "Oh, it looks like somebody was bleeding." And he said, "Oh, no, that is Betty juice, which is red. It's a nut that people chew and then spit out." There were piles of dirty, bloody OR gowns in the locker room. And when I commented to him, of course, coming from a sterile United States and seeing all of this, I said, "What about your hospital-acquired infection rates? And, you know, don't people get infected from having all of this?" And he said, "Oh, no, people are immune to the bugs. We don't have a high infection rate." And I don't think I'll ever forget, Gwen, the sight of those things that my medical background wanted me to shriek in horror. Now, that was, be clear, 1972. I'm sure it's completely different now. I came from a hospital environment in 1972 where you wouldn't see bloody old gowns laying on the floor over the weekend in an OR. And you wouldn't have spittle, for want of a better word, in the halls leading up to the OR. You would have a cleaner environment than that. So I do think we have to recognize that there are cultural practices and ability to access resources that are very different around the world. And we're talking about what happens in the United States, but it may not happen at all in some of the countries and people who are going to be listening to this podcast.
This is true. The World Health Organization is very active, of course, around the world. And one of their leading charges is hand hygiene. They do work quite consciously to spread the word about hand hygiene and breaking the chain of infection by using hand hygiene. And we have had people in our facility who do chew that nut and spit that juice. And yep, that I am aware of it.
Good. All right. I want to call it a beetle, but that's probably not the right word. It starts with a B, and somebody who's listening to me is going to say, "Oh, yeah, I know what that is." Let's go back to the question on the liability issues associated with the treatment of infection. And then I'll have just a couple more questions for you before we wrap up.
It's very important to be aware of the signs that someone is coming down with an infection. As nurses, we are with the patient 24 hours a day. Excessive pain, drainage from a wound, changes in temperature, changes in pulse, respiration, elevation of their white blood cell count. These are all things that a nurse should be aware of as they're taking care of their patient, and make sure that those are communicated to the treating physicians in a timely manner, because they are going to want to get an antibiotic on board or an antifungal on board, or evaluate the patient more completely to see if an antibiotic or an antifungal are appropriate, because there are certain bacteria that are very fast growing, that are very deadly. Two, I can think of where timing of the diagnosis are critical. Group A strep or Streptococcus group A, which can be a cause of what we call the flesh-eating bacteria, which can actually, you can practically see that devours flesh. They have to go to surgery very quickly for the surgeon to get a clean margin of flesh before that bacteria invades it. That is one that you have to act very, very quickly on. Another one I can think of is mucormycosis, which is a fungus infection that can kill an immunocompromised patient. And it can be in the air from moldy surfaces. And so that if you're doing construction in your facility and it's not airtight, or even if there's construction outside that's unrelated and the windows are open, this fungus can come in. And if you have immunocompromised patients in your facility, they can breathe it in, or it can get into a wound. If it's not recognized, a patient can die from this. And unless it's recognized very quickly and an antifungal is started, then it can be deadly for your patient. So timing and early recognition is extremely important for the nurse to pick it up and to communicate it to the physician.
That was one thing I noticed about the hospital in India, is that it didn't have any screens on the windows or any glass on the windows. So there was an open channel to any organism or any bug that wanted to fly into the hospital. Other infections where early diagnosis is critical besides the two that you mentioned?
Oh, there likely are. Those are the two that have the virulence that I can think of. But any infection can certainly go on and cause heartbreak for a patient. The deeper the infection, the longer it takes to treat it. If it gets into bone, that could be a 12-week intravenous treatment. If it gets into a heart valve, that is an extremely long treatment and could result in having to have the valve replaced. Any infection can be just horrendous for a patient. Long treatment and seeing them being out of work, and just, it can be horrible.
I know that our listeners are going to want to know what type of services you offer and how can they reach you. First of all, what type of services do you offer as an LNC with this specific background that you've got?
I offer a wide range of services, from record review, screening for merit, chronology. I can do expert witness review. I can work behind the scenes, help prepare witnesses. I can help find expert witnesses. Certainly been a nurse for a long time. I can review any type of medical premise liability or any type of nursing case, but infection is my specialty. And I can be reached at medicalinsight.com or grogers@medicalinsightllc.com.
Thank you, Gwen. This has been enlightening. I appreciate the tips that you shared. I would encourage our listeners who are asked to work on cases involving infection to consult with Gwen, bring her in as another person with specialized background. As Gwen has pointed out, there are a lot of implications associated with infections. As you talked about the necrotizing fasciitis, I was thinking about a woman who ended up losing her leg. It was amputated at her hip level because her whole leg was invaded, and it happened rapidly. It was a matter of hours. The nurses were describing
Yes.
this moving up her leg, and you could tell from their nurses' notes that it was progressing very quickly, and it was a med-mal case because the physicians didn't respond fast enough to it and caused devastating injuries to this woman. Well, thank you, Gwen, for being a guest on Legal Nurse Podcast. For you who've been watching this, stay tuned, or you're listening to it, stay tuned for just a couple more minutes. I'll be sharing with you who's coming up next. Be sure to reach out to Gwen for help on cases where her expertise can assist you. Thanks so much.
Thank you.
Coming up next on Legal Nurse Podcast, we're going to focus on one of the key things that is so important for developing your LNC business, and that is your online marketing presence. I have with me Barbara Levin, who has her bachelor's, her orthopedic nursing certification, her med-surg nursing certification, and her legal nurse consulting certification, who is a co-producer with me for our online virtual conference that we have twice a year. We just finished recording a live session with people who are legal nurse consultants on the topic of online marketing. You probably know me from being the host of Legal Nurse Podcast for 8 years. Barbara, do you want to do sort of a quasi-official introduction?
Absolutely. Pat Iyer has her master's in nursing and her legal nurse consultant certification. She founded and grew and sold a very large, successful, independent legal nurse consulting practice. It was called MedLeague, and it's located in New Jersey. She testified as an expert witness, an expert fact witness, and maintains a very active legal nurse consultant business. Pat is a past president of the American Association of Legal Nurse Consultants, the author of more than 60 books, and she's been a business coach for legal nurse consultants, a very successful and wise legal nurse consultant leader.
Thank you, Barbara. We covered in roughly an hour a wide range of topics. What were some of the topics that jump out in your mind, Barbara, that we covered?
We spoke about websites, how to develop them, what are the important things that you need to do with your website, how to protect your website from hackers. We talked about buzzwords and how to attract clients to that website, SEOs, how to use AI, and how to attract the ideal clients. We touched upon that, and there was a lot of intrigue there.
We covered a lot of topics in this hour and answered questions from the individuals who were present during this live program. We encourage you to go to the link that we described at the end, lnc.tips/September 2024 virtual, to register for our conference coming up September 26 and 27, 2024. If you listen to this podcast after that date, we will have the recordings of this 2-day live event available for you for your investment so that you can listen to the conference or watch the videos at your leisure. Be sure to join us if you can live. It'll be a lot of fun, lots of knowledge and support, and we will see you there. That's it for today's episode of Legal Nurse Podcast. Be sure to go to the link that I've shared with you, lnc.tips/September 2024 virtual. Get your ticket now and block the time off on your calendar to join us for 2 packed days of education, support, and networking. Join us then.